which will be sloughed off. So epidermis is comprised of 4 layers: stratum basalis, or the basal layer; stratum spinosum, where we have desmosomes between the keratinocytes. All of these things are very important because we will see diseases whereby the desmosomes are attacked by autoantibodies. So I can say the stratum spinosum is the thickest in the skin, where we have so after basal layer, so most of these cells with nuclei, they are stratum spinosum. Then you have stratum granulosum. Mubona hano hari ahantu hari dark aba ari umukara, niho granulosum, it refers to granules there which are black. So nta nubwo igaragara cyane, it is thin. Then we have a stratum corneum, which is this part which is not having nuclei. So just keratin, but you can see that there are cells, but no longer having the living nuclei. So hari indi layer itarimo yitwa stratum lucidum. Ntabwo iboneka muri skin zose, iba muri thick skin, like in palms or in the sole of the foot. Niyo mpamvu hano itavuzwemo, ariko you must know that for thick skin they have also a fifth layer, which is stratum lucidum. It is between the granulosum and the cornea. For the dermis, it is just connective tissue. It has nerve endings. It have smooth muscles, small ones. We have lymphatic cell, blood vessels, adnexal structures such as hair shafts, sweat glands, sebaceous glands, and so on. So it means also these epithelial cells in epidermis, they get their nutrients by diffusion. The nutrients are just brought here to the dermis, upper dermis, and then they will diffuse up to this layer of epithelial cells. So the epithelium normally is never vascularized. So no vessel should reach the epithelium. So the function of the skin, so here I think you can identify we have epidermis here and the dermis, where you have the sebaceous gland, and as you know, they are always close to the hair follicle. And then you have sweat glands. This is the so this sebaceous gland, they make a sebum. Ni nk'amavuta atuma umubiri ukomeza kurabagirana cyangwa se so ntukanyarare. So it is natural, we have that. So we have so others are muscles. Yes, erector pili. Nkuko mubizi, murabona ko ifitanye isano n'imisatsi aho iri. Niyo mpamvu rimwe na rimwe yavuze ko umuntu yagize uburakari bwinshi, imisatsi ikabyuka cyangwa igahindura uko yari imeze. Ntabwo ari exaggeration, ahubwo bibaho kubera ko these muscles they will respond to the parasympathetic system. Ku buryo umuntu arakaye, ntabwo ari utegeka ko izi hairs zihinduka, ariko iyo arakaye aba influence kuri izi muscles, imisatsi igahinduka uko yari imeze. Wenda bigaragara ko afite imisatsi miremire nk'abazungu. So the function of the skin, as you know, it protects us mechanically or physically, but also it has some immune processing it does, because we have like dendritic cells, which you know are very important. The first one is to culture virus and so on. And then when they culture this, they process and they present the antigens to T cells. How mubona HIV/AIDS, umuntu ayanduye na muri skin cyangwa se muri genital organs, reka tuyite nka skin. Dendritic cells nizo ziyifata bwa mbere, kuko ari virusi, nta n'ikindi kinini zikora ko ntiziyica, ahubwo muzi ko serire yabaye virus infected y'undi igomba kwicwa na T cells. Ariko HIV ifite amayeri, so when in the process, dendritic cells nk'uko mwabyize muri immunology, they switch the cellular to humoral immunity. So in such situation, aho kugira ngo switching ibe mu gihe cya HIV, nubwo ibaho, ariko ikindi nuko za viruses zijya no muri T cells, cyane cyane the infected CD4 T cells. Niyo mpamvu babona umuntu urwaye HIV bakunda gupima CD4 cells, nuko arizo HIV yica, ntabwo CD8 ntacyo zitwara. And this is CD4s, you know that they're important now to stimulate the B cells to become plasma cells and produce antibodies. So that's why HIV infected people, they have not only the problem of cellular immunity because CD4 are killed, but CD4 T cells, but also the humoral immunity will have a problem because the CD4 cells, which should trigger or activate or stimulate B cells to become plasma cells and produce antibodies, they are not there, so antibodies will not be formed. Mu ntangiriro zirakorwa, ariko uko immunity icika intege niko antibodies zigenda zikora. So that was just to explain how the skin, the structures in the skin, they will process immune complexes. So it holds that together, so it maintains all the organ imbere zikagumamo imbere, so uretse protection ariko no kuzigumisha hamwe. Thermoregulation, you know, when it is hot, you sweat to decrease the temperature inside the body, and when it is cold, you don't sweat, so the body tries to keep the temperature by keeping the water inside, so that you know. Sensation, touching, and metabolic, because as we have seen last time, so vitamin D is made at 85% out of the cholesterol, which is under the skin. So nyirango cholesterol hano ibiri muri hypodermis. So we have epidermis, dermis, and hypodermis. Hypodermis undi ni fat. Harimo za cholesterol n'izindi ngozi. So structures, as I said, we have epidermis, dermis, hypodermis, but also epidermal appendages, arizo za sebaceous gland, hair follicles, sweat gland, and so on. So this is again to show there's structures, vessels, and so on. So we don't have to keep much of time on this because you know it. But there are special cells we must mention, melanocytes. So melanocytes, they are actually at the basal layer around the basal layer of the epidermis. Niho melanocyte is it. And as you have seen in histology, melanocytes, nubwo zigaragara epithelial cells just polygonal, zifite branches, processes zigenda zigapenetra hagati ya keratinocytes or these epithelial cells. Nuko ziteye. And you know, this melanin they make is important not only to give us the color, ikibazo si color gusa, ikibazo ni no kubayo melanocyte, melanin, it protects us against the effects of ultraviolet rays. And this is why, as we know, or as we shall see, people are affected by albinism, so albinos, because they don't have a melanin, they are more prone to develop skin cancers because they have no protection against the ultraviolet rays of the sun. And also those with pigment, xeroderma pigmentosum, as we have seen in general pathology, who don't have, so they have a melanin, but they are not able to cope with the effects of the ultraviolet rays because they don't have the pyrimidine dimers excision repair mechanisms. So other cells are Merkel cells, so they are named like this because someone who discovered them is called Merkel. So they are cells which are found in the skin, ariko ntabwo kuri histology uretse igihe wakoresha special stain, ntabwo kuri histology bisanzwe ziba zigaragara. Melanocytes, you can see them because they contain melanin, but these ones you don't. But there are tumors, they make tumors which are aggressive. I think I have so far seen up such 2 cases of Merkel cell carcinoma. So they make tumors. So they are rare, and there's a tumors, we will not discuss them here, but you must keep in mind these ones. So these are the layers of the skin where we have the germinativum, or this is the first one, the stratum basale or basarum, and then we have a stratum mucosum or spinosum is the same, and then a granulosum, which have granules which are blackish, and then we have a stratum lucidum, which I said exists only in thick skin, and then stratum corneum, which we have just keratin, keratin debris. There are no living cells there. And even in stratum lucidum, you can see that new cells seem to be there, but no nucleus as in the lower layers. So in dermatology and dermatopathology, it is really a separate field. There are many terms which are very are specific to this system, which are not used in other parts of medicine. So that's why here we have the definition of some terms. So to help you to when we discuss, we say this disease is presented with this sign. I'm sure most of these terms you have not covered in the signs and the symptoms. And if you have covered it, that's good. But usually they don't present them in that chapter because they know you will cover them in dermatology. So I will not cover many of them also because you will have a course of dermatology where you will now to learn how to examine patients for dermatologic conditions, how to treat, and so on. And recently, the University of Rwanda has launched the postgraduate training in dermatology. So the first cohort is now in the first year, and so probably some of you will be interested in that also. So, and some of our pathologists also, they are doing dermatopathology to become super specialists in dermatopathology. So they are still looking for area universities or centers where they can be trained. So it is still in the process. But so far, the dermatologist we have at Sashwika, she is also strong in histology. She got a fellowship in Switzerland about the histopathology of the skin. So we collaborate very closely when we see skin lesions. When they are tumors, we automatically report, but when they are not tumors, we consult her, because usually in dermatology, you need to know exactly how the patient was looking like. So if you don't know that, at least they should give you enough information. And that's why in some countries, like in the United States, so usually the dermatologist should run also dermatopathology, so that he or she does examination, she does biopsy, and at the same time report and treat. So, but in a few centers, like in Boston, at Harvard, so that's what they do, which is good in a sense, but which also is not a good in other sense, because someone can be biased, because clinically I thought it is this, he may report histologically that it is what he was thinking. So njya mbibona kubera ko hari igihe dermatologist aba ateka ibi ngibi kuri histologist ukabona ibitandukanye, then kumukonvenka bikadutwara umwanya, ariko nawe akakonvenka avuga ati ntabwo ari byo kuko ibyo naketse. Ariko urumva ari we wasuzumye umurwayi agakora biopsy akanayiripotinga, there is a big risk ko yatanga diagnosis we yatekereje mbere, kubera ko hatabaye collaboration between two specialists. So the first term is the acantholysis. So maybe we can start with acanthosis is better. So acanthosis just means when there is the thickness of the epidermis has much increased. Epidermis has increased in thickness. So icyo gihe twita acanthosis. Nta nubwo bikoreshwa kuri skin gusa, no ahandi hose hari squamous epithelium, ko turikoresha no muri tusanzwe umuntu afite thick squamous epithelium in the tongue, in the esophagus, larynx and so on. Iyi term turikoresha. And then acantholysis, now it means when there is the loss of intercellular connection, za desmosomes navugaga mbere. Turagaruka ku ndwara ya mbere hano irahanditse yitwa pemphigus vulgaris, aho umuntu akora antibodies ziza zigasenya cyangwa zigashwanyuza desmosomes. As a consequence, we understand each epithelial cell will be separated from the other one. So akenshi ikibaho nuko bagira bule cyangwa se ukabona munsi ya muri skin harimo utu vesicles twuzuyemo amazi. Ni indwara ziba ziteye ubwoba, nubwo kuri history ubona hari utuntu duto, ariko clinically ni ibintu biba biteye ubwoba kubireba, wenda turi burebe amafoto cyangwa mwarayarebye. So for the acanthosis here, this is just a drawing. It is showing on the left here how the thickness of the epidermis is, and you see here on the right side that it has increased in thickness. So that is acanthosis. Atrophy, this is a general term that you have seen in general pathology. So it just means the shrinking or the size becomes small. So kuri skin tubwirwa n'iki uko habayeho atrophy. Icyano tubirebera nuko ubundi muri skin habamo ibyo bita ridges muri epidermis, ntabwo haba harambuye nkuko mubibona hano. Hari ibintu bimeze nk'amenyo y'urukero niko twabivuga. So niko uruhu ruba ruteye, ntabwo epidermis birambuye, ahubwo ibifite ibintu bimeze nk'imizi bigenda byinjira muri dermis. So atrophy rero ikiyaranga ni ugutakaza izo ridges niko bazita. So like here on the left side, you see that they are lost. At least on the right side, there are ridges that is kugaragara, but on the left we don't have them. So this is a sign. This sign is called atrophy of the skin. So basophilic degeneration, ibi bikunze kugaragara ku bantu bahora ku zuba, bari exposed ku zuba cyane, aho usanga muri dermis, we ikibazo ntabwo kiri muri epidermis bwayo. Muri dermis usanga collagen fibers zarabaye fragmented, zarabaye basophilic, zarabaye blue. So as you see here, these fibers in the dermis here, they are pink, but in when there is this basophilic degeneration, they become bluish and fragmented. So iyo tubonye tumenya ko umuntu afite icyo yabaye exposed ku zuba, tugenda tukunda kwita sun elastosis. So the elastosis, this is because these collagen fibers, they will look like elastic, so they will be coiled. Niyo babyita elastosis. So nyina abantu tuvuga rero nka albinos, umukoreye biopsy niba ajya kuzuba uhita ubibona ko kwajya kuzuba, ntawe yakoreye ngo sinkunda kubyicaraho, kandi bitubona kuri histology. Naho abandi ba ectodermal pigmentosa umuntu avuzeho cyane ubushize muri general pathology, nabo nuko nibi ubasanga. So blister, they are just these vesicles or bulle in the skin, as you can see here a picture. And the bulle is used, bullae, so it is used when that vesicle is larger than 5 mm. So turazireba intradermal, subepidermal, intraepidermal. So byose tureberera aho zitandukaniye bitewe naho iri, hari indwara bijyana nacyo. So nshaka mbakunda. So iyo hano afite nyinshi bulle here. So carcinosis, abantu bagira deposit of calcium muri skin gusa. Iterime dukunda kubikoreshaho ni carcinosis cutis. So cutis refers to skin. Carcinosis, not R, but L, carcinosis. So akenshi ugaragara nk'ufite iyi kanseri, ndibuka ari umurwayi boherejwe na referral hospital ya Kibuye, bafite kanseri bashaka kumuca ukuguru. Then we told them, first of all, do biopsy. Done biopsy, it was just a carcinosis cutis, and that we published that case. It was unusual. Just to publication, ntabwo ari ukugira ngo tugire publication gusa, ni ukugira ngo n'umuganga abuzaza nyuma n'abandi barahari ubu nabona case nk'iyo ajya anatekereza ko bishobora kuba carcinosis, ye gufata measures zikomeye atabanje kumenya a diagnosis. So on this uyu bafite gatoya hano ku rutoki, so nk'agasununu ariko wumva gakomeye nk'akabuye kane. So colloid bodies cyangwa civet bodies ni igihe some of the epithelial cells within the epidermis zabaye apoptotic zigahinduka umutuku. So which is shown here. There is an arrow I added there. So comedal hair follicle infundibular is dilated and plugged with keratin and lipids. So you have a drawing here. So normal skin pore here, and here you see that they are a white white accumulation inside, which would be maybe lipids, and here it is brownish. This is keratin. So azahita comedal gusa, ariko ijambo comedal ubwaryo tunarikoresha muri necrosis of tumors essentially. So cyst, I think this we have seen many times. So it is a cavity having a capsule lined by a true epithelium, and that cavity is usually filled with fluid. Let's see, there is usually there is a fluid. So when all these features are there, but there is no true epithelial lining, it is called pseudocyst. So there is an example here. So I made sure I add the diagrams or pictures to just to show you how they look like. So this keratosis, this is an abnormal premature keratinization of keratinocytes below granular layer. So you remember the histology granular layer is just after spinosome. So normally no keratin should be seen below granular layer. It should be in the lucidum, but essentially in the coroneum, stratum coroneum. No agomba kuba keratin. Ariko hari igihe bibaho keratinization ikazamo hasi. This is what it will be called this keratosis. So this keratosis, so the next term is epidermolysis. Epidermolysis, it means there is lysis in the epidermis, so destruction. This is essentially when there is alteration in the granular layer with perinuclear clear spaces swollen and irregular keratosis hair in the granules, such bodies twabonye, increased thickness, granular layer different. This is different from acantholysis. So acantholysis in the desmosomes gusa ariko epidermolysis, the features are shown here. Akenshi usanga harimo n'ibintu bimeze nk'amazi agatonga abyo bita spongiosis. Ikibazo ro clinical ni uko umurwayi agaragara, so umwana akwiye ko uriho foto ye hano, so usanga uruhu yunuka uruhu cyangwa se ashishuka uruhu. Gushishuka niyo usanga ushobora gushishuka akantu gatoya bitewe n'imirimo yakoze n'ikindi, ariko y'ibintu byizanye gutya nuko haba hari ikibazo gikomeye. You see that this is a serious disease. So epidermotropism ni ijambo rikoreshwa, epidermo murayo epidermis, tropism ni nko kushakisha. So ni igihe hari lymphocytes zishaka kwinjira muri epidermis, zishaka kwinjira, kandi ubundi ntabwo agomba kujya muri inflammatory cells kuko nta n'amaraso agera, nta lymphatic cells agera. So no inflammatory cells should be seen in the tissue which is not vascularized. I think you remember the definition of inflammation, but it happens in the skin that lymphocytes are seen inside the epidermis, especially in cutaneous T-cell lymphoma. So here they are shown the lymphocyte there. So when you see them, this is an abnormal. Erosion, discontinuity of the skin, nyango na magambo ajyanye na ulceration, ulcer, erosion, and so on. Nibijya kuba kimwe, ariko erosion is superficial kurusha ulcer. So there is a partial loss of epidermis in erosion, while for ulcer there is a complete loss of the epidermis, and the drawing here is showing that. So erosion, a part of the epidermis, this blue layer is lost, but in the ulcer, not only the dermis, but also a part of dermis is also lost. So this is the ulcer, ulcer of the stomach, and atakaza mucosa, ahantu hamwe na hamwe hakaza igisebe. Excoriation, deeper linear scratch, are often self-induced. So excoriation ni ukuvuga hari umuntu yirya inzara, hari n'abantu so ngira ngo muzabona muri hari reality nyinshi hanze aha ngaha muzajya mugeraho z'ibintu bibaho udashobora gutekereza. So umuntu wenda akirya inzara akishwaratura kugira ngo aze kuvuga ngo jyewe bambiye inzara, abakobwa batiye bo umuhungu cyangwa umuntu ashatse kumfata ku ngufu dore n'inzara yandiye. Ni bita self induced. So bibaho si ku bana bonyine, abantu abadolescente n'abantu bose bashaka ni amanyanga murabyumva. So ibyo bintu bibaho cyane. Benda ikibikemura ni igihe hari abantu bize bazi ibyo bize, nk'abantu bize forensic. Iyo wabyize self induced traumatism urayimenya, niyatewe n'undi muntu hanze ukayimenya. Ibyo ni ibintu biba bitandukanye cyane, ari approach. So cyakora ari umuntu wabikoze anazi uburyo ibyo biba identified, wenda ashobora kubigeraho. Ariko abenshi iyo ashaka kubikora gutyo, yazi ko ibyo wikoresheje babivumbura, areba ubimukora. So icyo cyo urumva kiba kigoye kuzavumbura ko yabwiye undi muntu abimukora, aho kiba kigoye. So rimwe when I was in Dar es Salaam studying, so we were talking with my colleagues, my housemates. So twari twagiye ahantu hanyuma tuhura no polisi. So we present ourselves. So abandi twari abanyarwanda babiri n'abandi ari abatanzania. Hanyuma so tuvugaho dukomoka, ati ndibuka nigeze gukora mu gice cy'Akagera cyegereye iwanyu, ariko twahuriye n'ibibazo byinshi. Ngo hari impunzi z'abanyarwanda zagiye muri 1994. Hanyuma murabizi ko amahanga akunda kuza gushaka muri izo mpunzi aho bajyana, n'ubujyamo mubyumva n'impunzi ziri mu Rwanda, za Canada n'ahandi, bakaza bagajyana mu impunzi. So impunzi rero zimwe kugira ngo zijye muri ibyo bihugu biteye imbere, zigakoresha amanyanga. So yatubeti baragendaga umuntu akavuga ati, akaza akaripotinga muri HCR ngo jewe hari abantu tubana hano banyanga, bambwira ko bazanyica. Ati mwarebye ukuntu mu njyana mu mahanga. Kunyora akavuga ati nose ibyo ngibyo ni bituma ujya mu mahanga. So iyo yabonaga ntacyo yabikozeho rero, yaragendaga akareba mwene wabo akamubwira ati we fata umupanga unteme, ntunyice ariko unteme umbabazi, kugira ngo babayobozi baze kubonaho ko mbangamiwe. So ni ubwa mbere nyumvise umupolisi abivuga, sinzi ko ishaka kuvuga. So hanze hari ibibazo byinshi na hano ibyo gufata ku mutwaro ngaha mu Rwanda n'ibindi. So there are many issues. So exocytosis, normal appearing lymphocytes in epidermis, in spongiotic dermatitis. So epidermotropism na exocytosis igenda kuba kimwe, gusa exocytosis ntakoreshwa lymphocytes. Any other cells which can be seen inside the epidermis, it will be called exocytosis. So hydropic or liquefactive degeneration. Here, basal cells, they become vacuolated and separated and disorganized, and you can understand the consequences. Nuko bisa naho the environment izahita ihura na dermis with severe consequences. Ko epidermis una kazi kamwe mu kazi gakomeye ikora nuko kuba epithelial cells zifatanye bituma nta kintu kizimeneramo, nta mazi, nta bacteria, nta virus, uretse igihe habayeho akabazo, igihe habayeho agasebe cyangwa kwangirika gato. Otherwise ntabwo ibintu bishobora guhitamo. Ariko iyo hajemo ikibazo nk'iki degeneration, then anything can diffuse through them. So hyperkeratosis, thickened coronified layer. So ni igihe abantu bafite coronified cyangwa stratum coroneum yabaye nini cyane, very thick. Nkuko mubizi n'ubundi thick skin zacu mu kiganza no mu kirenge harba hari ziri thick kubera ko zifite rusidamu itarahani. Ariko ikintu kibigira thick cyane nuko bifite ubwabyo hyperkeratosis. So iyo tuyibonye turavuga ati afite hyperkeratosis, but which is normal because of the location. Ariko tubonye ahandi hantu hari thick kurusha uko byagombye kumera, icyo gihe tuvuga ko ari abnormal. So hyperkeratosis then it has two variants. it can be orthokeratotic, ni ukuvuga igihe nta nuclei ziri muri coronified muri stratum corneum. Mu gihe parakeratosis ni igihe tubona nuclei within the stratum corneum. So these terms are important. So ushobora kuvuga ngo ibyo nta kintu kinini bivuze, ariko bitewe n'uko umurwayi n'icyo afite, hari indwara byendeka idafite aho ihuriye n'iyi, and the treatment will be quite different. So this is a acanthosis to show increased thickness of the stratum spinosum, ntabwo ari corneum. Noneho hyperkeratosis ni ikibazo cyane muri corneum. So it is orthokeratosis when these cells don't have a nuclei here. It will be called parakeratosis if these cells here contain nuclei. So hypergranulosis also exists. Aho granular layer ubona yabaye kwishona cells ziri dark, ariko navuze karabamo dark granules. So lentiginous ni ijambo rikoreshwa iyo habayeho proliferation of cells, cyane cyane bikoreshwa kuri melanocyte within the dermis, ariko proliferation ikaba epidermis, ikaba linear cyangwa se ikaba superficial, bitinjira muri dermis. So this is epidermis, is in retiriges, nkugira ngo ni melanocytes zamanutse hasi ni retiriges, nuko mubyibuka. Retiriges ni igice cya epidermis kinjira muri dermis, naho igice cya dermis kizamuka muri epidermis cyitwa this is dermopapilla cyangwa papillary dermis. Hanyuma dermis hasi kitwa reticular dermis, but you know in history. So lichenification ni igihe uruhu rwakagashe rugakomera nk'ibyatsi byitwa lichen mwize muri secondaire. Ntabwo ari ibyatsi, bya bintu bitari ibyatsi bifatwa nka plants ariko zitari plants, kuko ntabwo yigira photosynthese n'ibindi, cyangwa indabo cyangwa ikinyama, ize algae, lichen n'ibindi. Ikindi igihu gikomeye nk'icy'inzovu cyangwa se ibiti nk'amapinusi n'ibindi. So nibyo iri jambo nicyo ryerekeza. So hari igihe uruhu rukomera gutyo bitewe no kwishimagura, and you can see this picture here. So please an example. Of course, ibyo turi kubona byose hano ni terms, they are not diseases. So there are diseases which will have this sign. The Lichenoid interface change bikoreshwa igihe basal layer in epidermis has been destroyed by the inflammation coming from the dermis. So icyo gihe ugasanga junction between the dermis and the epidermis has been destroyed. When you have such a thing, we call it interface dermatitis, cyangwa se lichenoid interface dermatitis. So iyo uyibonye rero hari indwara ihita ikujyana. So ibi byose bidufasha to narrow down the differential diagnosis. So macule ngira ngo ni igihe umuntu afite akantu ku ruhu katabyimbye ariko kahinduye kala kandi kari flat hejuru, niyo macule. Aka ngaka ntabwo habyimbye, nta nubwo okay, hejuru hari flat, ni ikibazo cya kala change radius. So nodule is the solid, deeply extending region more than 5 millimeters, like this one. Onycholysis ni term ikoreshwa igihe hari inzara zigize ikibazo. Lysis, you know, lysis, it is destruction. So the nail here is destroyed. So papillomatosis, I think you remember papillomas and human papillomavirus ni tumeze nk'uduparike twinshi dushaka kuza ku ruhu or any other organ or on a surface of any organ. So patch is a flat discoloration. Ni kimwe na macule, ariko patch ni nini kurusha macule. Macule is less than 5 millimeters. From 5, then it will be patch. Otherwise, they are the same. So in here they are presenting the same diagram. So macule, this is small, and then patch, this is large one. Papule is a solid elevated region. So no hari akantu gasa akarabyimbye kagiye hejuru, elevated. So ntabwo kari kuri level y'uruhu, ahubwo karazamutse hejuru. Iyo ni papule iyo ari gatoya, yari kanini n'ubundi ni nodule when it is solid. So plaque, it is elevated, irazamutse hejuru ariko ntigire dome ahubwo hejuru ikaba flat. So urumva ni nka nodule ariko igeze hejuru ikaba flat, yitwa plaque, ntabwo ikiswe nodule. So purpura, this is the term you have seen in hemodynamic changes, extravasation of red blood cells into the skin or mucous membrane, ariko ntabwo ari extravasation ya yose, ni tuba ari duto cyane purpura. Purpura ni tunini kurusha petechiae. So petechiae ni utuntu duto cyane, ni pinpoint one, ni nkaho ari ahantu bajomye udushinge, mu gihe purpura ho kaba ari akantu kanini ukabona kuko nta kuri iyi shusho bigaragara. Pistil, it is like nk'uko twabonye vesicles, but when the vesicle is filled not by fluid but by pus, icyo gihe yitwa pistil. Ntabwo uba ugikoresheje ijambo bule cyangwa vesicles, you must use the most specific term. Yego ni bule cyangwa se ni vesicle, but to help others to understand more, or at least to make a diagnosis, you must use the most specific term, which is here pistil. So sinus, it is a tract connecting cavities to each other or to the surface. I think this is the same as so. Iyo umuntu afite fistile ni uburwayi, ariko fistile iyo connection between one organ and another organ, iyo connection y'ubwayo yitwa sinus. It is a sign. Spongiosis, when someone in his or her stratum spinosum, they have intradermal edema, and usually with vesicles inside there. So hari vesicle ubwayo, ariko na ahatari vesicle hagati ya cell n'indi hari ahantu hari whitish, meaning that there is a fluid there. So you need spongiosis. It looks like a sponge. So it is caused by rupture of the desmosomes. Acantholysis. Ulceration, we said it is more deep, it is deeper than the erosion. Vesicle, it is fluid filled area 5 millimeter or less. Naho bure 5 millimeter or more. It is more than 5 millimeter. So uko mubibona these terms, I have listed them according to the alphabetic order. So with it is each transient elevated area with variable blanching and erythema due to dermal edema. So ni ijambo wenda tudakunze gukoresha cyane, but in dermatology they use it. So that's all for the term. So ikindi rero kiza muri dermatopathology, and if you want to be a dermatologist, you must know nuko diagnosis yose ikorwa tubanza kugira icyo twita patterns. Icyambere bareba ese uyu murwayi afite spongiotic lesion, ese uyu murwayi afite interface dermatitis, yani navuze. So iyo umaze kuyigeraho, iyo ngiyo niyo twita pattern of the disease. Noneho ureba differential diagnosis which are possible. So cyane cyane nka pathologist, when we look at the slides, then ukabona after interface dermatitis. So uhita usubira muri clinical information, ukareba ibyo bavuze, ibyo baceka, ukareba muri differential diagnosis batanze, ukareba ijyanye none interface dermatitis, akaba ariyo ukareba ko bihuye, then ukemeza. Byaba hari ibindi ukeneye special investigations or studies ukabikora. But to know the pattern is very important. Hano muri dermatopathology, it is also important in the soft tissue tumors, when navuze ho bushize. And we don't diagnose, just to give a diagnosis without first of all saying, you describe what you see, then you conclude to a pattern you are seeing, then after the pattern you give a differential diagnosis, and among them you will have to retain only one diagnosis to allow the treatment of the patient. So eczematous pattern, eczema ubundi ni ibintu usanga mu ruhu hari kunyanya amazi, nicyo nshaka kuvuga eczema. So iba hehe, iba nko ku bantu bafite atopic dermatitis, nuko atopic it refers to allergic dermatitis. Hari igihe utazi ikibiteye, rimwe kwa muganga bakakubwira ati bishobora kuba ari imyenda wenda mwanitse ahantu hanyuramo ibisimba runaka then ukagira allergy kuri byo. Usually it takes time to know what have caused that. Bishobora no kuba ari imiti cyangwa ibyo umuntu yariye gusa icyo gihe biba hose, ariko yari igice kimwe cy'umubiri ni uko hari ikintu cya contact kiba cyane. So scabies ni ikintu ntabwo no kwahita mu Kinyarwanda, ariko ni ibintu abantu barwaraga bishimagura bishima. I don't remember the term in Kinyarwanda. So macula and papilla rash. So macula you remember cyari cyo and papilla. So ijambo rash iyo rikoreshejwe muri dermatology birashaka kuvuga ko umuntu yishimagura. So ibyo rero biza mu bihe abandi bagira papilla and macula rash. Harimo afite T-cell lymphoma. This is a cancer of the T-cells within the skin. Hamwe n'abafite eosinophil and so on. So another pattern is urticaria. Urticaria pattern nabwo barishima, but there are you see that afite ibintu bimeze nk'ibifaranga hano ku ruhu bitandukanye nabo abanyezi bagira amazi eczematas cyangwa se bagira bariya bagite nodule or macule. So iyi urabona ko ni plaque y'ubwayo, it is elevated and it is flat at the surface. So blisters and pustules. So blisters ni bya bindi bagira bulle, vesicles and so on. Na pustules byose biraho hamwe. So hari ibintu byinshi ushobora kuba uzafata diagnosis, but at least you should conclude this patient is affected by a blistering condition. Nodular lesions. So nodular, they can be caused by anything, nodules, and they are listed here. Then vascularitis, so inflammation of around the vessels. Birumvikana iyi ni diagnosis ukora kuri histology, not diagnosis, a pattern that will be described on histology. And then a fibrosis, which can come from any reason. So the pattern of dermatosis by category, so here we can see that you have a pigmentary disorders, urticaria and erythema, skin tumors, papillosquamous disorders, appendages, connective tissue, parasitic infestations, dermatitis and eczema and so on. So bigaragara ko ari nazo nyinshi z'ingezi kwishimagura no kunyanya amazi. So that's all for this introduction, and then we shall start with the first group of diseases. But if you have a question, you can ask. Okay, so inflammatory dermatosis. So we start with atopic or eczematous dermatitis. So when I visit to the indwara here, you cannot discuss everything, and nobody knows everything because sashe kadufite ibitabo binini cyane bya dermatology, dermatopathology binini cyane, kimwe gifite pages zirenga 1000. So ni ibitabo bitatu kandi nabwo ntabwo biba byaramaze indwara zose ngo bizivuge. So this is just to make understand that there are so many entities that cannot be discussed. Even those who will be specialization in dermatology or super specialization in dermatopathology, they will not cover everything because there are always new entities. Hari izo double chongeramo, hari izo bakuramo and so on. So things they keep changing. So this is the pruritic. So pruritic and erythematous, there will be reddish lesions, oozing. So it discharges fluid with vesicles and edema. Involves the face and the flexure surfaces. So these are affected by type 1 hypersensitivity reaction associated with asthma and allergic rhinitis. So I think this, in immunology, we have 4 types of hypersensitivity reactions. So nkuko byumvikana ibintu byose hano bigaragaza ko ibifutano bafite allergy. So contact dermatitis navuga bwa mbere nayo ni pruritic, erythematous, oozing rash with vesicle and edema. It arises upon exposure to allergens such as poison ivy and nickel jewelry. So bari abantu abagore cyangwa mbona n'abagabo bahari bambara ibi bintu so biba iyo contact so akambara ibikomo bya biti bikamutera allergen so cyangwa isaha nayo ubwayo kubitera. So there are also irritant chemicals such as amasabune amwe namwe, drugs, penicillin. Treatment involves the removal of the offending agent and topical glycocorticoids if needed. So first of all, when you have identified the cause, then you have to correct that, and then if it is needed, you can give the drugs to the patient. These are corticoids with their consequences, of course. So this is showing how this happens. So we have a dendritic cell here in epidermis. So this dendritic cell will process the antigens, and then these antigens will be presented to lymphocytes, or especially when this dendritic cell ikoze muvoma ikavana ikagenda ko zirabikora ikajya muri lymphatics, then ikajya muri lymph node. Iyo bigeze muri lymph node, za antigens iyi dendritic cells, it presents them to lymphocytes. Then these lymphocytes zizakora cascade zo gukora memory T cells, which will recognize that antigen the next time it will come. Cyangwa icyo ni kimwe. So hahita habaho memory T cells, ariko hakabaho na antibodies nazo zikorwa noneho zikaba ziteguye na plasma cells zizaya zikoze antibodies cya kintu nikigaruka. So niko allergy bigenda. So iyo umuntu yongeye agafata ya allergen, so reaction ya kabiri is very intense, very intense. Ngira ngo iki ngiki mugomba kucyitaho kubera ko nimutangira kuvura muzamure excited kwandika imiti cyangwa and so on, ariko muzajye mwibuka bugiye kubaza uburwayi nta muti ujya ugeraho allergy. Ndibuka hari histoire yabayeho, nta nubwo ari kera, nta myaka iri kurashira, ku bitaro bimwe hano mu gihugu, ntabwo ari i Kigali, ni hanze ya Kigali. So hari umurwayi ugira allergy ku miti ya penicillin, nuko za amoxicilline, za clamoxil, iyo miti yose no mu bwoko bwa penicillin. So noneho yararembye, ari mu bitaro arembye, hanyuma nyine bamukora file babyandikamo ko afite allergy. So haza undi muganga ku izamu, umuganga aje ku izamu, aba agomba kwakira ripoti y'abarwayi bari cyane cyane nk'abo barembye cyangwa baraye mu bitaro. So ripoti ntiyayihabwa, ahubwo na file ye abantu ngo bari bayijyanye, niba ari muri investigation zindi bari barimo bakora itari aho ngaho. Ntabwo nzi exactly why the file was not there. Ni ukuvuga umuganga abona umurwayi ararembye, abura icyo akora, file ntihari, arabaza, abanasi bamubwira ibi n'ibi, so arabateka no tumuhaye umuti. Ntiyamenya ko wa muntu afite allergy kuri penicillin, yari amaze no kuremba atashobora kugira kuvuga. So amuha umuti, then consequence yamuhaye nuko yagize allergy none hatari kuri penicillin. So allergy ya mbere kenshi nta ni ikintu umuntu atita akaba ari gata, ariko allergy ya kabiri kuri cya kintu aba ari akaga gakomeye. So icyabaye nuko yagize consequences zikomeye, cyangwa bagera ubwo bamuca ukuboko, and so byamenyekanye kubera ko ibyo bitaro byagombye kwishyura amafaranga menshi. And so you can understand the consequences. Now we can million zirenga 60. So you can understand these consequences just because you maybe you didn't take care of the history allergy. So then this challenge here is that now when the allergens will come for the first time, murabibona hano habayeho akareaction gato, but here you see the reaction. You see here many antibodies here, maybe many cells. So that's why the reaction will be very intense. so noneho rero niba ari bya bintu abantu bambara ahozamo birumvikana ntazaba yanagikuyemo, sensitization izahita ikomeza vuba vuba, so usange afite dermatitis common. So acne vulgaris, comedone, white hairs and black hairs, pustules, and nodules is extremely common, especially in adolescents. So ngira ngo ni bya bindi ukunda gufata mu nk'abasore mbona abakobwa ariko barabigira aba adolescent ones. Cyane cyane biza ni ku basore aho ahashobora kumera ubwanwa niho bikunze kuza, ko bijyana na hair follicles. So hormone associated increase in sebum production, so iriya sebum twabonye kare iba nyinshi ikuzuramo hariya noneho bikabyatangamo inflammation and so on. Ubwo izo hormones birumvikana ni ziriya za puberty ziba zazamutse ari za estrogen ari na testosterone. So psoriasis, this is a disease where circumscribed salmon colored plaques. So salmon nuko ibiba bijya gusa n'ifi, donc ubu usanga umuntu afite uruhu rusa n'amagaragamba y'ifi. So you can see it here. Usually on extensive surfaces of the scalp. Surfaces in the scalp. So ni ukuvuga niba afite ku kuboko azabigira ku nkokora, ntabwo azabigira hano hino ukuboko, azabigira inyuma ku nkokora ubwayo. And this is important. So ni usanga umuntu afite region ijya gusa gutyo ugasanga ayifite kuri flexure surfaces, then wowe ugahita ucheka psoriasis wabyishe, kubera ko at least as I said you must know the most frequent things. So iyi psoriasis ikunda gufata. So until so abarwayi nanjye nabonye ku giti cyanjye benshi baba bafite mu mutwe kurusha ko bafite ku maboko no ku maguru, abo nabonye personally. So you can see how they are. Bimwe bimeze nk'ibifaranga, but they are ibifaranga bindi birarwaye biti ibifaranga bimeze nka, so uruhu ntabwo rufite scars cyangwa ibintu bivubuka nk'ibi ngibi. So ni indwara hano muzarimo babona benshi muri iki gihugu. So on histology, because there are differential diagnoses, iyo ubonye gutya ntabwo uhita wemeza psoriasis, you must do histology. Histology dusanga afite elongation of lateral ridges ariko ziba ziresha hano, niyo mpamvu bayita afite ikimenyetso ibyo bita the signs of the y'urukero, uko amenyo y'urukero ameze ni kuko ziba ziresha izi lateral ridges. So they are very tall. Noneho urebye hano muri epithelium usanga harimo spongiosis. So this is low power spongiosis. Iyo spongiosis rimwe namwe wasangamo inflammatory cells, neutrophils, icyo gihe bakabita micro abscess. So this is frequent, and they usually this is to know the cause is not, the causes are not known. So here they say possible autoimmune etiology. So nobody knows exactly why it comes. Usajya abantu nabo yafite n'abantu usanga bafite psychological issues. Abo nabo, but I don't know if all the cases are like that. So lichen planus, mirango babyumva lichen rwa rumeze nk'urw'inzovu cyangwa planus, these are flat. The regions are flat. Uko mubyibuka lichenification twabibonye muri patterns aho umuntu afite inflammatory cells at the junction between dermis and epidermis. So urabona ni aka inflammation gusa kabaga kuri histology, but clinically aba afite ibimenyetso bibi cyane, uruhu rwarabaye gutya. So biba bimurya pruritic, they are plan or flat, polygonal, purple papules often with reticular white lines on the surfaces. This is called the Wickham stria. So usually I seen on the wrist, elbow, and oral mucosa. Oral involvement manifests as a Wickham stria. So there will be inflammation at the remote epidermal junction with a sawtooth appearance. So sawtooth ni nayo seen na kuri psoriasis. So the etiology is not known also here. Ariko byagaragara ko abantu benshi bayifite baba banafite chronic hepatitis C virus infection. So eczema, bishobora kuba ari byo kera abanyarwanda bitaga ibinyoro, n'ubwoko bw'ibinyoro ubu ngubu nta muntu ujya wumva bavuga ngo kanaka arwaye ibinyoro, ariko kera barabivugaga, cyangwa iyo musoma amateka y'u Rwanda banga ibinyoro cyangwa ibiki babaga bafite ibintu. So this is contact dermatitis. There is a local reaction to toxic agent. So on histology, you have epidermospongiosis. This is epidermis, but inside the epidermis you can have, this is a cavity filled with a fluid. So usually there is a poison. Shakora acid munakozemo cyangwa bamumennyeho and so on. So urticaria yaba nka diagnosis of exclusion. Iyo umuntu yishimagura bashaka izindi mpamvu zose bakazibura, nta kintu ari afiteho allergy kiri specific kizwi, ahubwo ni uko arayishimagura, icyo gihe indwara y'umwe bashobora kwita urticaria. Otherwise it can be just pruritic lesion which is a sign to a specific disease. Yendagiza allergy ku nzuki, bee sting, and so on. Ariko ikibazo nuko hano it is generalized. Normally when someone is got a bee sting, agira allergy aho ngaho gusa, it will not be generalized. So this is mediated by immunoglobulin E. So there is too much histamine release. There is vascular dilation. Remember, histamine, its actions include vascular dilation, increasing vascular permeability, and the vascular dilatation. So I'll be fluid in the tissues. So that's all for these regions. So the next part will be blistering dermatosis. If you have no question. So blistering no tugiye kugaruka kuri za zindi ziba zimeze nk'utuntu zuzuyemo amazi mu ruhu, ubona zuzuyemo amazi. Ahangaha ngira ngo turanareba ikintu gisa n'arisha cyangwa navuzeho muri Dermatopathology, the regions of the kidneys. Twabonyemo indwara zimwe na zimwe udashobora microscope isanzwe itagira icyo ikoraho, so molecular yo nta ruhari bifitemo, ahubwo ukenera immunofluorescence na electron microscopy. So navuze ko no muri skin hari indwara zibikenera, ni zero tugiye kumenya. So immunofluorescence and electron microscopy. Icyambere turitaho ni ikirere, nuko cleft imwe iza muri mu ruhu bitewe n'ahantu iri bifite icyo bivuga. So nk'ayi cleft murabona ko subcorneal ya tumocoroneum na granulosum iri hejuru cyane. So iyo kuri histology bigaragara ko ari hiri, iyo ndwara yitwa impetigo. When it is suprabasal, so just above the basal layer, the stratum basale here, iyi akenshi igaragara mu ndwara bita pemphigus vulgaris. Naho iyo cleft ndwara za lysosomes n'ibiki byacitse iri subepidermal, munsi ya epidermis, munsi ya basement, wenda munsi ya basement membrane and so on. Dufite indwara ebyiri zizwi cyane. Iya mbere ni bullous pemphigoid, indi ni dermatitis epidermiformis. So muri dermatology harimo amazina menshi ari platinum and so on. So we start with pemphigus vulgaris, ariko region iri muri epidermis, ariko just above the stratum of basal. So clinically this is how it presents. So uruhu rusa n'urweguka, munsi hakazamo amazi, ubibona. And on histology, as you see here, there is a stratum basalum iri hejuru ya basement membrane, and then the cleft is here. The upper part of the epidermis, you see that it is a home. So there is the autoimmune destruction of the desmosomes between the keratinocytes. So there is the IgG antibody against the desmograin, and it presents as a skin in the oral mucosa bure, as it is seen here. So igihe hari ni acantholysis nk'uko twabonye dutangira of stratum spinosum keratinocytes, which as you know are normally connected by desmosomes. and this will result in suprabasal blisters. So the basal layer remains here via the hemidesmosomes, and you always believe histology. Basal layer is connected to the basement membrane using hemidesmosome, not desmosome. Desmosome is there between the peripheral cells and the cells. So immunofluorescence using so immunofluorescence bivuga iki ni staining ukora ufite ikintu uri ushaka kudetect ukaba ati nshaka kureba ni harimo IgG. So in that case then you will use the stains which are specific for IgG. When IgG is there, they will react and then give this color, this greenish color. So IgG will surround all the keratinocytes in efficient pattern. So efficient around ukomeze niko mubibona. So utu tw'icyatsi kibisi ni just surroundings of each epithelial cell. An epithelial cell ni hariya hari umukara mo hagati. So niko igaragara bivuga ko izi IgG ubundi ziri ahantu hose around all keratinocytes nubwo cleft yo yabereye ahantu. So murabona ko itandukanye n'ikurikiyeho bullous pemphigoid, and you can see clinically how to present. Hariyo umuntu ukavuga uti ukagira ngo ntabwo ari umuntu. Niyo waba usanga umuzi kandi murabeshya ntabwo ari. So kubera ukuntu aba yahindutse complete kugira ngo ntabwo akiri umuntu yabaye nk'inyamaswa. Kubera uburyo abasa. Cyane cyane iyo byafashe mu maso. So here in bullous pemphigoid, there is a distinction of hemidesmosomes, not desmosomes. Hemidesmosomes, which are between basement membrane and the stratum basale. Niyo mpamvu habaho kwa epidermis yose. So yakabaye kagenda hakazamo bure hagati. So kuri immunofluorescence hano murabona ahari umuhondo ujya kuri cyatsi kibisi niho nyine badetecte IgG. So will make see. So iyo ufite electron microscope, this IgG so that's why I said these two things they go together. So another disease is dermatitis herpetiformis. So ntawe ihuriye no kumuntu afite herpes infection, ntawe ihuriye no ko yiswe gutyo. So the position at the tips of dermatopathology. So dermatopathology is okay. This is epidermis. So where the epidermis goes down into the dermis, not beta retinitis. Aho dermis izamuka muri epidermis niyo bita dermatopathology. So hano rero niho ikibazo kibera muri iyi ndwara dermatitis herpetiformis. Izi dermatopathology zigira ikibazo immunofluorescence mu kubona deposits. And now it is IgA, not IgG. So muri rusange rero navuga is the blistering lesion. We can diagnose them. We use just histology. Sometimes we use special stains. We don't have the immunofluorescence, and as you know, we don't have electron microscopy in Rwanda. So immunofluorescence at the King Faisal Hospital, they have the facilities, but they don't do, and no explanation with that. So the facilities are there to do so for skin and for kidney, but they don't do. So probably in the future they will. So another disease, erythema multiforme. So erythema, whenever there's skin or mucosal or redness, you can call it erythema changes. Erythema changes. So this they will have a bulle and most commonly associated with herpes simplex virus infection, but also people who have infection with mycoplasma, or those who react against some drugs such as penicillin and sulfonamides. Bajya babigira sulfonamides hari imiti umuti witwa Bactrim watangwaga cyane muri prophylaxis abantu bose bafite HIV ataratangira imiti ya HIV kubera ko nyine bayitangaga umuntu afite CD4 cells nkeya, bamuhaga bactrim nka prevention of opportunistic infections. So icyo gihe rero bactrim irimo it has two drugs combined together. One of them is sulfonamide. So hari ababigiraga allergy. I remember when we were students at medical school, we had a case at such children afite icyo bita Stevens Johnson syndrome kubera ko yari yagize allergy kuri izo sulfonamides. It's very difficult. So I'm sorry, I don't know what happens. Sorry, I lost connection to the Teams. I don't know the reason. So we can proceed, and I hope you can hear me. And I'm going to share again the screen. So we were just finishing this part at the temamatiforme. I was just giving an example of the case of Stevens Johnson syndrome that we had. So probably these cases will be few because Bactrim is no longer being used as a prophylaxis of opportunistic infections in HIV patients. So the next part is the infectious disorders, and we start with leprosy. And this is what I was mentioning. Leprosy is nowadays very rare, but this is a disease which has been in this world since many millennia of years. Because if you read the Bible, you know this was there quite long before the birth of Jesus. So many thousands of years. So nowadays the WHO, they are striving to eradicate this disease, but it will not be easy. Kubera ko hari igihe na mu Rwanda tuvuga ngo it is eradicated. So hashira iminsi ingahe mukajya kumva hari cases zabonetse Bugesera, Bweyeye n'ahandi nk'aho ngaho. So that's why I say although it is very rare, murumva ko n'indwara ifite some I can say not political, maybe political implications, because the word iri ni imwe mu ziri targeted ko zigomba kurandurwa. So ntabwo ari nicyo nshaka kuvuga. So niba rero icyo gihari ni ukuvuga ngo nuyibona ntuyimenye zaba ari ikibazo gikomeye. So that's why you must discuss it, although it is very rare. So it is called also Hansen's disease. Kubera ko iterwa na bacteria yitwa so it is Mycobacterium leprae, ariko initwa Bacille de Hansen mu gifaransa mu cyongereza komye. So it has many forms. Hariyo bita tuberculoid, lepromatous, indeterminate, and histioid forms, and so on. So we shall see some of them. So it is a very serious, mutilating and stigmatizing disease in many parts of the world. So ngira ngo kuvuga ko ari mutilating wayibona hari abituma batakaza ibiganza, amano, and so on. And stigmatizing nkuko mubibona no muri Bible ubwayo. In the Bible you saw that the people who were affected by this disease had to be quarantined. So ntabwo bagomba kwegera abandi bantu bari. No kuhegera byabaga ari icyaha, bashaka no kwicwa. So byatuma rero bagomba kwihisha ntibagaragare mu bandi. And it is still like that. Icyambere icyo byakorerwaga icyo gihe ntabwo kwabaga ari urwango rundi, yari mechanism yo kugerageza guhagarika ubwandu, kubera ko ni indwara yanduza umuntu ntabwo ahirwara atandujwe n'undi. Umugero w'irwaye bamushyiraga mu kato kwa ngo atanduza abandi, ni icyo cyabaga kigamijwe. Ariko nkuko mubizi, if you read the Bible thoroughly, you will find that now it became like a sign of someone who has been cursed. Niyo muntu urwaye ibibembe, leprosy n'ibibembe, bifatwa nkaho ari umuvumo yashyizweho n'Imana, niko babifataga. Nkuko na hano sida itangira kuvugwa cyane, umuntu ntabwo yirwaye nyine bamufataga ari igihano cy'Imana, kubera ko abantu bose bumva ko yayanduriye mu busambanyi n'isoni. So byenda gufatwa kimwe. Yenda sida kwandura kwayo ntabwo ari accidental nka leprosy. Ko leprosy ushobora gukoraho umuntu uyirwaye yakoze aho yari yicaye ukandura atanahari. So wenda biratandukanye. So early diagnosis and therapy, they are the only strategies to control this disease. It is highly infective, but has low pathogenicity and low virulence with a long incubation period. So irandura cyane, ariko uburwayi bwabo bugaragara bitinze. Ndetse binavugwa ko, I think it is on the next slide, but it affects skin, nazo mucosa, peripheral nerves, and so on. So icyo nashaka kuvuga nuko yes, incubation period bamwe bavuga ko ari imyaka 5. Incubation, you know, kuva igihe wanduriye kugera igihe uzagaragaza ibimenyetso. So navuga ngo incubation period ya malaria no kuva igihe umuntu yarumiwe wa mubu kugeza igihe azagira ibimenyetso niyo ni incubation period, you know that. So hano bavuga imyaka 5 but nobody knows, kwa ko icyambere nta numenya ngo yanduriye, keretse ndakuvuga ngo abana n'uyirwaye, ariko se niba abana n'uyirwaye bakabana azamenya ngo ni iyihe tariki yanduriye, kuko ashobora kubana akamara umwaka cyangwa amezi angahe ataramwanduza. So iyo byose rero bituma ntawe umenya exactly what is the incubation period. It is also thought that there is some genetic predisposition, some think about this, and ikindi kizamo nuko bavuga bati abantu babana hari ubwo babana ubuzima bwabo bwose ntibanduzanye, ndetse bakaba bati hari na conjugal leprosy, low incidence of conjugal leprosy, ni ukuvuga umugabo akayirwara n'umugabo akayirwara, ariko bakazarina basaza uwo bashakanye akayirwara kandi babana mu buriri. So ibyo byose bituma hakomeza kuba ibibazo, none se niba yandura cyane kuki wowe atandura? So many questions there. The port of entry, nkuko tubana ngo maraya ni umubu utwinga umuntu, hano it is not well known. Gusa bizi ko bishobora kwa ni ku ruhu, upper respiratory tract, they are probable, so bakavuga ati umuntu yamutsiriseho uruhu arandura, ariko bikaza no kuki umugabo atanduza umugore buri gihe atari buri gihe amwanduza. Ikindi ni droplets nk'izuko n'iza covid zigenda agenda mu droplets umuntu akabihumeka bivuye ku wundi. So that's what is the thing. So kuba hari vectors n'ibiki byose, these are just assumptions, nobody knows exactly. It is clear indwara imaze imyaka 4,000 cyangwa hafi 4,000 ihari, ariko ibi byose akaba ataramenyekana. So ni nkaho hari ibintu bitasobanutse. So there is a spectrum of clinical characteristics which correlate with histological changes and also immunological status. So ni spectrum kubera iki? Ubundi hari amoko abiri akomeye ya tuberculosis. Hari iyo bita tuberculoid, hakaba n'iyo bita lepromatous. So hagati yazo harimo izo bita borderline. So muzamona bavuga ati uyu afite borderline tuberculoid leprosy, ni ukuvuga afite ibimenyetso byinshi afite n'ibya tuberculoid n'ubwo wenda afitemo n'utundi duke twa lepromatous, cyangwa se akaba borderline lepromatous ni igihe afite ibyazomba ariko cyane cyane higanjemo ibya lepromatous. Hano bita borderline ari hagati na hagati. So ntabwo ari umurwayi aba ahwanye n'undi, byanze kunza ari utuntu batandukanye. So tuberculoid rero irangwa n'iki? Tuberculoid leprosy aba afite paucity of organism, so few bacteria. So this is will be called the paucibacillary leprosy. And then the manifestation is that they will have a few lesions because they have a few bacilli. Also, they will have a few lesions, and superficial nerves may be enlarged. There will be palsy or paralysis or joint nerve abscess. So this is seen in highly resistant people. N'uwana afite immunity ikomeye cyane nibo bameze gutya. Ngira ngo ibindi tuvuga mwabonye muri inflammation with tuberculosis. Na tuberculosis irimo iyo bita paucibacillary, akaba iyo bita multibacillary. So paucibacillary iba ku bantu bafite immunity ikomeye, bagira granulomas zikomeye nini, mu gihe multibacillary ni bandi ba HIV positive bafite weak immunity, bafite many bacteria and so on. So this is more seen in India and Africa, and you can see the region. Kukabona nk'ibintu kiri banaka ngo n'ikintu cyamukubiseho, but rimwe na rimwe akakubwira yumva ari gutakaza kumva anesthesia. So kuko icyo ni kimwe kibaranga ku buryo ashobora kuba asinziriye wenda nko mu Kinyarwanda abantu babaga bicaye imbere y'iziko bota bataramye, akaba asinziriye wenda agasinzira itotsi ikamutwara akazishyira ikirenge mu muriro ntabimenye, abantu batabibona agashya kubera ko the nerves are no longer functioning. So the promatous leprosy ni ya kategori ya kabiri. So you see that the lesions are many on the body. Harimo niba bibyimbye nk'ikibyimba bwawe ni ikibyimba kindi, and you see uruhu nk'urw'ingwe ariko rumeze. So this is multibacillary leprosy, numerous lesions Usually it affects the skin in a symmetrical way. So ni ukuvuga ntabwo ifata uruhande rumwe, both sides. Multiple small macules, infiltrated plaques, and nodules with poorly defined borders. Multiple facial nodules give a bovine appearance, usually sparse eyeball. So associated with defective cellular immune response, I was explaining this. So rimwe na rimwe atakaza nezo symptom ugasanga afite nk'izuru rimwe mu mazuru nyine ari abiri we ukabona afite rimwe. Ngira ngo biba kuri aba bafite leprosy, ariko hari n'abantu banywa ibiyobyabwenge bya cocaine nabo nicyo kibabaho. So the nerve lesions will cause acral anesthesia, meaning anesthesia of extremities. Bigatuma agira foot drop niba ntabwo niba uko babyita mu kinyarwanda, bamwe bagenda bashinze ikirenge, amano bagendera ku mano, none mbahawe quality babyita mu kinyarwanda. So icyo ni kimwe, but at the end usually they lose, they can even lose this kuko yakandagira mu musumari, yakandagira mu muriro, yakandagira mu cyuma, ntabwo abimenya. So they have various autoantibodies. So it is like consequences. They started to develop autoantibodies. Some of them, they will also cause the destruction of melanocytes and as you understand, the person will develop a vitiligo. So borderline tuberculoid, borderline erythromatous nibyo navugaga, bitewe naho umurwayi ari cyane. Yaba ntaho hari afite 50-50 between tuberculoid and erythromatous, niyo bazita borderline inshuro ebyiri. So they are listed, they are shown here the pictures. But I remember when I was in primary school, hari umuntu twajyaga dukunda guhura tugiye kwiga, yari afite uruhu rumeze gutya, twakunda kumenya ntitumenye ibyo ari byo. So when I start to run at medical school, niho nitayere wa muntu burya yari afite ibibembe. So there is also repranulitis, ni igihe iyo repra yafashe gusa nerves ahandi nta lesions ubona. So this is an example. So kuri histology rero ahangaha ariko bakoze stain nk'iya tuberculosis, zitandukanira ko imwe hari ahantu ugera ugatwika ibyo uri gukoramo experiments, ni muri tuberculosis. Iyo ushaka kureba niba afite leprosy ntabwo agutwika, bayita rero cold desire Nielsen stain. So murabonamo utuntu tumeze nk'utu byatse bacilli no dem, tumeze nk'utuvirigire duto cyane dutukura. These are the bacilli for leprosy. N'iza tuberculosis ni nako ziba zimeze. So you see that there are so many here. So this is probably a case of multibacillary leprosy or lepromatous leprosy. So there are differential diagnosis of leprosy, meaning ni indwara zishobora kugaragara nkayo ku buryo buri gihe iyo ukeka you must exclude one and one another until you reach the final diagnosis. So, okay, I still having the problems of interruption. I don't know the reason, because the internet is strong. Okay, so let's finish this part before we go for a break. So I hope you can hear me and see the screen.
Yes, yes.
So I was just about to say about to present this differential diagnosis of leprosy. So showing that some of them, they have clinical features similar to those of leprosy. So the reason why when you have such conditions, always making investigations like a biopsy will be a good move. So this is the leishmaniasis here on the left upper left. So I have not personally seen any patients in Rwanda, but in Ethiopia, I saw many cases there. Mu maso kugira ngo ni ikintu cy'igikanseri, but being just this is an infection. So lichen planus twayivuzeho hejuru, afite uruhu rukagashe nk'urw'inzovu and so on. So ichthyosis vulgaris, so it seems like just a leopard as it is in leprosy. So biopsy will be important here. So rhinoscleroma ni indwara hano mu Rwanda irahari nyinshi turazibona kenshi, afite ibibyimba abenshi mu mazuru and so on. So we diagnose them many times, iterwa na bacteria. Yitwa nayo rhinoscleroma and so on. So hari indi ndwara hano wenda we have not presented here yitwa rhinosporidiosis. So ni personally, I saw it first time at Sashika as a pathologist. Then I failed to know because it was my first time to see it. So then I asked advice from a colleague at the Brigham the Women's Hospital of the Harvard University. Then he told me, no, this is rhinosporidiosis. Ariko kuva icyo gihe twahise tubona 4 cases, we published them. So ikibazo twasanze ziva ahantu hamwe mu ntara y'Iburasirazuba, akarere ka Kayonza, uretse mu murenge umwe, uretse umuntu umwe wari mu wundi murenge nawe wegeranye naho mu kandi karere. So ibyo twabigize ikibazo, impamvu ari ahantu hamwe. So we alerted aba bayobozi ngo bazarebe ikibazo gihari ko ni indwara scientifically bamwe baravuga ngo ni parasite, abandi bakavuga ni fungus. So there is no consensus until now uburyo igaragara, ariko abafite nawe ibintu mu mazuru kuriya bintu. So recently twabonye indi case ya mbere i Kigali, naho twarayibonye. So hagati aho ngaho, so those who have seen that publication, hari abandi bantu batari abaganga bakora ubushakashatsi mu bintu bya kinyamaswa n'ibiki bisanzwe, bavumbura ko hari ubwoko bw'iyo parasite cyangwa fungus, ko ntawe uzi icyo ari cyo hagati y'ibyo. Nshasha babonye mu Rwanda bayita Rhinosporidiosis rwandae, ntabwo hashize amezi make bayibonye. So baradusaba ko dukorana ngo tumenye niba izo twabonye mwabo barwaye ari iyo ngiyo. So we are working on that. So it will require to make a molecular testing, genomic testing, kureba amagene yazo uko ameze, niba ayo tubona mu barwayi ameze nk'ayo babonye, kuko bayibonye mu bikeri, babibonye mu bikeri, babonye ko ari ubwa mbere bonetse ari mu Rwanda, bayibonye bwa mbere. So it is what we are going to do. Maybe this year, then we are in the process gukora sequencing of the genome of our cases and compare with that parasite or fungus they have seen in the frogs. But I went back into literature. I found that before the genocide also hari cases nk'abari barabonye muri ibi bice mu Rwanda, nyabazari nk'eshatu, mu Burundi, muri Congo. So they are published by people from the region. So it is quite a new feature. We don't know exactly how to deal with it. So how are they transmitted? So byose tuzabijyamo turebe, tubaze abarwayi, imiryango yabo, abenshi ni n'abana, tubaze babaho bate, turakunda kujya mu gishanga, yaba yandura nk'uko schistosoma yandura. So we don't know. In the literature there is nothing about that. So dermatofibrosarcoma protuberans twarigarukaho, parapsoriasis, so ijya gusa na psoriasis twavuze, and then atypical mycobacterial infection, n'abantu barwara ibintu bimeze nk'iby'igituntu, so atypical mycobacteria. So murabyumva ko n'izi za leprosy mycobacteria. So impetigo is another infection caused by Staphylococcus aureus or Staphylococcus pyogenes, and we can see aravuvuka, agashishuka, and so on. Usually affecting skin. They have erythematous, meaning redness, macules that progress to pustules. So they start as macules. They progress until they become pustules, meaning filled with pus. So the rupture of pustules, it is that in erosions and the dry, crusted honey-colored serum. So cellulitis, it is just inflammation of the deep dermis and the hypodermis, subcutaneous, usually due to Staphylococcus aureus and Staphylococcus pyogenes. Presents as a red, tender, swollen rash with fever. So ahangaho biba bimurutse, tender and swollen. So murabona ugereranyije mu birenge, this is red, this is swollen, and so on. Uyu we ngira ngo bimaranye igihe, babona ko uruhu rwatangiye gushishuka, n'uruhu hasi rurashishuka. So this is an emergency, a surgical emergency, cyatse gufungura ugakora debridement, kubera ko aba harimo ibintu byaboreyemo n'ibiti byose ukabikuramo. Is necessary, otherwise there will be no healing. So it is a surgical emergency. Staphylococcus scalded skin syndrome. There is sloughing of skin with erythematous rash and fever leads to significant skin loss. So ubwo birumvikana ko igomba kubitandukanya na za pemphigus, blistering lesions. Gusa zo zirimo amazi, ahangaha it seems no fluid, cyetse hariho infection yazanye pus. So usually due to Staphylococcus aureus and so on. So you can see here and here. Verruca, this is due to HPV infection of the skin. Akubita amasununu n'ibindi, ariko amasununu n'ubundi ni iyi ngiyi molluscum contagiosum, iranandura cyane, bazaba harimo ijambo contagiosum. So there is a flame of pink umbilicated papules due to poxvirus affected keratinocytes will show cytoplasmic inclusions, maruscum, bodies. So you can see them here, the cells which are more blue, their nuclei are very blue because they have inclusions, so by these viruses. So most often they are seen in children, but also occur in sexually active adults and so on. Ngira ngo nibyo bakunda kwita maruscum compared amahumane and some ibyo and some amahumane bavuga ngo bayabirenze ahantu and so on. So I think then we can have questions and then break. If now we come, we are going to proceed to of tumors essentially. Any questions? So if no questions, then we can have a 10 minutes break and come back to continue.
nareka tujyayo kandi urufunguzo rwa perezida wanjye
telefone iyi telefone ni yande
ni ya Felix one
ntabwo mbizi
Can you hear me now and see the screen? So I suppose so. So there is an issue with sharing slides. I don't know what happened. So we proceed with the disorders of pigmentation and melanocytes. We shall start with the disorders of pigmentation themselves, and then we proceed with disorders for the melanocytes, where we shall see tumors essentially. So as a basic principles, you know that melanocytes are responsible for skin pigmentation and are present in the basal layer of the epidermis. We have seen that. So they are derived from the neural crest. This is embryology. They synthesize melanin. Melanin, it is stored in melanosomes using tyrosine as a precursor molecule. Tyrosine, you know, this is one of the amino acids. So then the melanocyte, they will pass melanosomes to keratinocytes. Niyo mpamvu kuri biopsy ntabwo melanin aho uyibona burya ari muri melanocyte gusa, ziba zagiye no muri epithelial cells, because epithelial cells, they need them to protect themselves. So this is what is shown here in this diagram I added. So we have a neural crest from which they have a migration of melanoblast. Melanoblast will be differentiated into melanocytes, and they will come from dermis to the epidermis. So this is a migration. Then after that, they will divide to be many, and they will have to synthesize melanin out of tyrosine, and they will use an enzyme called tyrosinase. And then this enzyme will help them to form melanosome. So melanosome here, it is empty. Then this it is ni nko wakora container noneho ukazana ibyo uyihunikamo. So habanza gukorwa aho melanin ibikwa, no melanin ikabanza ikabona gukorwa ikazanwamo, and then that's melanosomes container imaze kuzura izoherezwa aho igomba kujya. So niyo mpamvu hano yoherejwe muri melanocytes. So iyo yoherejwemo melanine ikakirirwa muri keratinocyte, muri keratinocyte cyangwa epithelial cells, then melanosome cyangwa ya container irajugunywa, so ni nka barrage irajugunywa. So that's how things are done. So the diseases then vitiligo twayivuzeho cyane, localized loss of skin pigmentation because melanocytes are destroyed by autoimmune things. So I think I have explained much about this. This is a disease which has far no treatment. And as I said, I know there are many industries and researchers working on that. Cyane cyane abo muri Canada kuri iki, hari abo muri Canada nzi bari kubikora research gukoraho kureba imiti ya vitiligo. But so far no approved drug to treat vitiligo exist. Kuko zasana abantu bakomeye cyane bafite ubushobozi ariko bayifite batageze bavurwa. So of course the affected area will be exposed to the ultraviolet rays ku buryo ashobora kugira ibibazo bya kanseri nka albinos. So albinism, congenital lack of pigmentation, aha ni ikibazo cya tyrosinase idahari ituma hatakorwa melanin. So albinism, there is a lack of melanin. Vitiligo, there is a destruction of melanocytes. It may involve the eyes, both eyes and the skin, oculocutaneous form. So they have increased risk of squamous carcinoma, basal cell carcinoma, melanoma due to reduced protection against ultraviolet rays type 2, type B. Ultraviolet rays harimo ubwoko bwinshi A, B, C. Iyi B ni itera amakanseri cyane. So C bivuga ko nayo yayatera, ariko ozone kaga yunguruzo kaba kizuba karayifata. So this is what we know. So and I think I have given you the examples. I have seen many cases of albinos who developed skin cancers when I was in Dar es Salaam, because they have many albinos people there in Tanzania. So they used to to have you can see just one patient having like 3 cancers in different areas. Ugasanga hari afite mu rutugu, hari afite ku kuboko kumwe, hari afite ku kundi kuboko and so on. And their problem is that, as I said, they are advised to cover themselves, bakambara neza, bakikiriza, ntibambare ubusa, cyane cyane abakobwa bakunda abo nabonaga bakora. So babona urundi rubyiruko rwambara ko rubonye nabo bakajyamo kandi bakabigisha ati mwebwe mufite ikibazo cy'izuba ariko ntabwo baba bashaka kubyumva. Abana basaba kwambara zino ngofero nini z'urugara, hari iziba ari nziza ari estetike, ubona umuntu asa n'uwarimbye, ariko byose hari abatabikoza cyane cyane abatoya. So none nabonaga yakaza afite kanseri ebyiri eshatu ahantu hatandukanye, cyangwa se uyu munsi bakamuvura, hashira amezi akabona aragarutse yazanye indi kanseri ahandi hantu. So it is really a big challenge to treat them. Fleckled, so epheris, it is a small tan to brown macule which darkens when exposed to the sunlight. So this is due to increase the number of melanosomes. So wenda niba twahita indwara cyangwa atari indwara, ariko birumvikana iyo agiye ku zuba ryinshi umubiri uhita ukora melanosomes nyinshi, nyine ukuzuzamo melanin kugira ngo wirinde iryo zuba. Ayo mpamvu bizamuka iyo agiye ku zuba. Melasma, this is a mask-like hyperpigmentation of the cheeks associated with pregnancy and the oral contraceptives. So you can understand that there are implications of estrogens and so on. In that case, cyamuzamubona n'abadamu batwite hari n'iyo bagira kunda iyo atwite, abenshi bagira umurongo uva hejuru umbilical ukamanuka ukagera hepfo kuri pubis w'umukara. Yamaze kubyara uragenda wa murongo yenda mu minsi mike uba wagiye. So it is also hyperpigmentation. So now we go to tumors, nevus or more. So it is a benign tumor of melanocytes. So it can be congenital at birth, and usually in that cases it is associated with hairs. You can see this figure on the right. But it is not. And this is not an exaggeration. I have seen a similar case in Dar es Salaam. So after nevus ku umubiri hose kuva ku ijosi ukamanuka ukagera kuri hafi kuri thighs, hari ikintu kimeze gutya, ibibyimba. So you can't do anything with that. You cannot do surgery. There is no treatment. So it is a big challenge. So apart from congenital nevus, there are also acquired nevus which arises arises at retinal. So nevus ni kamwe yari myinshi ni nevi, cyangwa nevi. So this acquired nevus begins as a nest of melanocytes at the dermal-epidermal junction, and in that case it will be called the junctional nevus, and it is the most common more in children. So it grows by extension into the dermis, nibwo yitwa compound nevus, iyo yagiye muri dermis hasi. So junctional component is eventually lost, resulting in intradermal nevus, which is the most common more in adults. So this is like a pathophysiology. So in children, they have a junctional one. But as time goes on, the part of the epidermal nevus is lost. So the child will remain, or adolescent will remain only with dermal nerves when they become adults. So we have many pictures. Yes, uzayitubona kenshi yukabonye very dark. Of course, amaso ntabwo yagufasha kwitandukanya na histology na melanoma na cancer. So usually they need biopsy. So I know there is a colleague here from Rwanda when he was doing oncology. So in Dar es Salaam, so bakoze application muri phone bashobora gukora bagafotora akamol, noneho harimo akantu kameze nka artificial intelligence kakaba kakwerekana niba ari melanoma cyangwa se ari nevus. So it was just for the purpose of research, ntabwo ikoreshwa in clinical settings. So they are a flat macule or raised papule with symmetry, sharp borders, evenly distributed color, and smaller diameter, less than 6 millimeter. So dysplasia may arise. So it means if someone has nevus, it is not something to keep. So because at any time a dysplasia may come, which is a precursor to a cancer, to melanoma. So the location, as we said, it can be epidermal, dermal, or compound. So hari indi twitwa spitz nevus, which affects young people. It looks like aggressive. Cyane cyane kuri histology ubona ari nka melanoma neza neza. So usually you can, if you are not careful, you can misdiagnose it as a melanoma. So halo nevus, it is when the tumor, the nevus is having regression, which starts inside. So muri centre ugasanga hatangiye kuba hazima hasigaye ku ruhande. That case you record halo nevus. So melanoma now, the cancer, it is a cancer of melanocytes, and this is the most common cause of death from skin cancers. Birumvikana navuze aho impamvu muri cancer register badashyiramo za squamous cell carcinoma nuko abati ni gute umuntu utekereza ashobora kwicwa na squamous carcinoma of the skin. So that is the Europeans and Americans. So that's why they don't put it in cancer registry. They put in skin cancers, they put only melanoma. Others say, no, they should have seen that on due time and then prevent its spread. So melanoma birimo izuba ryinshi ariko bafite n'uruhu rudafite melanine nk'iyacu. So niyo mpamvu ibihugu bishyuha cyane nka Australia abagira melanoma nyinshi. Of course in Europe also they have, like in Sweden where I was, so there are many cases of melanoma. Kubera igihe kigera guhera mu kwezi kwa gatanu haba hari izuba, kugera mu kwa munani haba hari izuba, nyuma nyine haba ari urubura n'ibindi, ariko icyo gihe izuba rihari rishobora kwangiza uruhu rwabo. Kandi ikibitera ni iki? Kubera baba baramaze igihe kinini batabona izuba, iyo rije ahantu hose baba bishimye, abantu baba bambaye ni bake. Abantu baba bambaye ni bake cyane cyane abazungu, wenda abirabura kugerageza kwiyuba. So benshi usanga birirwa bambaye underwears gusa, cyane cyane abadamu, abagabo wenda bambaye amakabutura gusa, bitaritse kuri iryo zuba kuko batariheruka. Baba baruhutse gufata ya supplementary vitamin D. Ariko kubera uruhu rwabo, then they will be exposed to melanoma. So risk factors, they are based on DBV-induced DNA damage. So this is a kind of ultraviolet rays. So induced DNA. So this rays, they induce DNA damage. So it comes when someone has been exposed to sunlight, especially in albinism. Those with xeroderma pigmentosum. Additional risk factors are dysplastic nervous syndrome that we talked about. So clinically, the signs of melanoma are represented in 5 letters of alphabet: A, B, C, D, E. So mu bitabo bimwe na bimwe bazavuga A, B, C, D gusa. Asymmetry, asymmetry. So nevus twabonye ko ari symmetrical. So meaning the right side will look like the left side of the lesion. But in melanoma, the side here right will not be looking like the left one. So this is asymmetry. Borders are irregular in difference to navy. The color is not uniform. You can see how it is brown, other areas dark brown, other areas are light brown and so on. So the diameter is usually more than 6 millimeters, so it becomes D, and then evolution nuko ko igenda ihinduka, ntabwo iguma ko yari imeze nyuma y'amezi usanga ari byahindutse. So you can see the lesion here ifite mu maso, so hari uyifite hano mu kirenge, afite ku mano. So I think what we see in Africa essentially nabayigira kuri extremities no wita acromelanoma. Rero dukunze kubona cyangwa no mu kirenge ki. So nta nubwo ari ikintu kigoye kuyikora diagnosis. Uzasanga ari umuntu ufite ikibyimba cy'umukara, uburyo ngo na makara neza because of melanin, black melanin that we have. So that is what we see in a candle. So as the doctors, so what you will have to be careful of is you don't have to do surgery on melanoma if you are not sure you will remove it completely. Because when you do a biopsy on the melanoma and the pathologist reports that the margins are negative, you can be brought to the court. Ko bivuga ko umwishe cyangwa atazamara kabiri. So that's why if you want to do surgery, ensure you can remove completely the tumor and even with some normal tissues. So meaning with negative margins. So this is a condition. Otherwise, when I see a melanoma case that they have not done a proper excision, I become also upset. So it has two growth phases: radial growth or horizontal growth in epidermis. So you can see, as you know, the melanocytes they are located in the lower epidermis. So when there are malignant cells here, also the growth will be radial or horizontal like this. But when it takes a long time, if surgery is not done, then it will proceed with infiltration of the dermis, and you can see that vessels are affected. In that case, distant metastasis also will happen. So this is vertical growth. Hari ibyo dupima muri histology, hari factors zimwe za prognosis nababajijeho, so I will have to submit of course today. So kimwe mu byo dukora ni breast row thickness. No kuvuga kuva kuri surface kugera aho selile ya nyuma igeze hari milimetero zimwe centimeters zimwe. This is important because if it is 1 millimeter, it is likely that umurwayi azakira. But if it has taken 5 or 6 millimeter or and so on, the prognosis becomes worse. So that is breast row thickness. Turapima tukabati breast row thickness mwabona muri report zacu ni 4 millimeter, 5 millimeter, or tukabati ntago dushobora kuyipima kubera ko bamubaze nabi. So in that case, umuganga ahita mukorerwa gusa ahita ajya mu bibazo. So hari indi twakoraga mbere ariko it is no longer done, aho twavuga ngo igera muri dermis gusa, muri upper dermis, lower dermis, muri hypodermis and so on. So yari ubundi buryo, ariko breast row niyo nziza niyo internationally it is the better one. So the variants included the superficial spreading, ikura ikomeza gukurikira muri epidermis gusa, which of course will have a good prognosis. Kubera ko icyambere murumva ntabwo igera kuri blood vessels or lymphatics and so on. Lentigo maligna, it has a radial growth, but it proliferates much and usually it goes down. So it has also some good prognosis because it is superficial. Acral lentiginous, it rises in the extremities, as I was saying, and it is the most common in blacks, at least in our country, but also in the literature it is shown in the individuals who are dark skinned. So now it is not much related to ultraviolet rays. Kubera ko n'ubundi ushobora gusanga umuntu n'ubundi ahora yambaye inkweto yari ku zuba ariko ugasanga ni ku kirenge yafashe. So nodular, it shows the vertical growth. So igitangira imanuka muri dermis ikajya muri vessels and so on. So it has a very poor prognosis. So hari indi rero histological type yitwa amelanotic melanoma, idafite melanine na gato, ku buryo ntabwo iba ari umukara nko kuzindi zisa, ahubwo no kuri histology it will be very difficult. Dukora immunohistochemistry kugira ngo tumenye ko ariyo koko. Otherwise, you cannot see it on histology or clinical. So there is a concept called the sentinel node. So sentinel node nubwo tuyizanye hanga ntabwo ireba melanoma yonyine. Sentinel node ni iki? Urebe ku igishushanyo umuntu yari afite kanseri hano mu kuboko. None icyo bashaka kumenya ese kanseri yaba yarageze muri lymph nodes and thus ikajya no muri distant organs maybe. Because the melanoma as the other carcinomas, they go through lymphatics, niyo mpamvu aricyo bareba. So what they do, they inject a blue dye, so ibintu biba byarabugenewe bisa na blue, bakabitera mu kibyimba. Ko baravuga bati n'ubundi any foreign body is injected or inside the body will be channeled toward the lymphatics. Bityo iyi fluid bamuteye byanze bikunze za muri lymphatic vessels. None icyo bashaka cyane ni ukumenya lymph node ya mbere iragiramo n'iyi. icyo bashaka kuvuga ngo lymph node ya mbere kuko hano muri agisilamu zuko harimo lymph nodes nyinshi tuba turimo duto cyane ziba nini iyo umuntu arwaye nibwo zigaragara utahize ntabwo don't palpate them, don't feel them. So lymph node ya mbere aho basanze yagezwe muri iyo fluid baravuga bati niba hari amaseri ya kanseri yatambutse nta handi yaba yarageze na ya lymph node ya mbere niyo bakora biopsy bakajyana muri histology bakaba niba harimo cancer cells. So ni icyo sentinel node. So ishobora gukoreshwa muri cancer nyinshi za carcinomas, those which spread through lymphatics. So iyi ni principle na hano mu Rwanda bajya bakunda kwitaza hamwe se mukora sentinel node and so on. But it is nowadays a problematic kubera ko icyo ni kimwe ariko ikindi cyasanzwe nuko iyo bakoze injection lymphatics igira tendency of being obstructed, especially then it will cause lymphedema, ukuboko kukabyimba uburyo byari ikibazo gikomeye. So iyo ni risk yayo, but otherwise it was helping much. Any question? So I didn't go into details about the prognostic factors because I asked you to mention them. Okay, so we proceed with epithelial tumors. So we start with seborrheic keratosis. You see the picture here. So it is benign squamous proliferation, common tumor in the elderly. So it is raised discolored plaques on the extremities or face, often has a coin-like waxy stuck-on appearance, as you can see. So characterized by keratin pseudocyst on histology, as you can see. So we have a pseudocyst in harahari empty, whitish. So it is pseudocyst because they are not lined by epithelial membrane. So that is one. Another one, this is not a true tumor. Ahubwo lesion nziza ku mubiri because of the sun. So there is a solar exposed skin lesions here because of epithelial proliferation. Usually they present with dysplasia. Okay, me as a pathologist, I can see dysplasia here in this epithelium. So it has a high malignant potential. So uzasanga abantu bagira squamous cell carcinoma of the skin because of the sun. Usually they start with actinic keratosis. Acanthocyst nigricans. So acanthocyst, we have seen that it means increase in the thickness of the epidermis. So nigricans, it means there is a black discoloration. Epidermal hyperplasia with darkening of the skin, velvet-like, often involves the axilla or groin, associated with insulin resistance. Example, non-insulin dependent diabetes or malignancy, especially gastric carcinoma. So bivuga ko umuntu abifite ushobora kubifata nka trade of boteng nk'ibintu biranga ubwiza ariko this should be an alert. So keratoacanthoma, it looks like a cancer clinically, but also on histology, it looks like a squamous carcinoma. So this is a challenge. So someone can be misdiagnosed with the cancer while it was just this keratoacanthoma. So one of the signs that it will regress. Niba umuntu yari expert ku zuba bakavuga ati ntukajye ujya ku zuba, this mass will regress. So you can say it is not a true tumor. So a cancer called basal cell carcinoma. So this is an exception. The exception of cancers which never metastasize. So iyi rwose umuntu yica haba harajemo uburangare bwe cyangwa rw'azabe cyangwa rwo kwa muganga kubera ko ni kanseri yenda gahoro cyane. It doesn't metastasize except in very rare cases. So turazibona nyinshi izi ngizi muri skin amashyashya turazibona ariko ni ikintu baga igashiraho bagataha ntagizagira izindi nkunye. Igihe margin ziri negative, of course. So squamous cell carcinoma, so it is a proliferation of squamous cells with keratin formation. So ifata hariho hose, muri babana bite albinism, eczema pigmentosome, and the other risk factors listed here, chronic inflammation. Ngira ngo twabivuze tureba osteomyelitis, those having burn or draining sinus tract. So niba umuntu yarahiye ahantu, yaba ari heat burn cyangwa se chemical burn, ni byiza ko abantu aharinda guhara exposed ku zuba kubera ko afite risk yo kuzanira squamous cell carcinoma. So ikindi ufite osteomyelitis kandi amashyira asohokera mu ruhu handi haba hari risk yo kuzanira squamous cell carcinoma. I have mentioned this last time. So the tumor can be acerated or just nodular, and it involves anywhere. So hari abo tubona bifite mu maso, hari ababifite ku munwa, hari ababifite ahariho hose, anywhere, ku birenge, ku maguru, and so on. So hari nabo barinda bacaho akaguru kwa yagitindanye basanga even the bones have been affected. So the last part is dermatomas. So as I had mentioned when we discussed the soft tissue tumors, I said that there is a cancer affecting mostly people infected by HIV called the Kaposi sarcoma. Kaposi no umuntu, so this is a eponym. This is a vascular malignancy, and as I said until now, so nobody knows if it is from lymphatics or blood vessels. So there are many theories around this. But what it happens, this is caused by a virus called HHV8. This is human herpes virus type 8. So murazi is caused by type 1, type 2, 3, 4, 5, 6, so on, 8. So HIV/AIDS, the advent of HIV/AIDS has caused the increase in the incidence of Kaposi sarcoma. Cyangwa mbere aho mu Rwanda ushobora gusanga nta Kaposi bari barigeze babona, but when HIV/AIDS came, so we had many cases of Kaposi sarcoma. N'igihe nakoraga muri district twarazibonaga abarwayi ba HIV bafataga immunity yabo yaragiye hasi cyane, so twarababonaga. Nowadays they are few. So we have a clinical and pathological stages. It's a patchy stage, and they are shown here. So patchy stage and the plaque stage, patchy abari nka macula, ntabwo baba habyimbye. Plaque haba habyimbye ariko hari flat, then nodular ni ikibyimba kigaragara. No kuri histology tuhita tubibona. It's not difficult to see so. So the diagram here above is showing that when someone is affected by HHV8, banaita Kaposi sarcoma herpes virus, cyangwa se human herpes virus type 8. First of all, this virus will induce the proliferation of the vessels, so angiogenesis, endothelial cells mainly. So, and there's endothelial cells themselves, they will release cytokines, and these cytokines will either go straight forward to activate again other endothelial cells. So this is an autocrine loop. So you see that the cytokine comes again to activate the endothelial cells to make more vessels. On the other part, we have also HIV/AIDS, as I said, which has increased much the increase in the incidence of Kaposi sarcoma. So it has many proteins. The 30 protein from HIV will also make sure there is a proliferation of endothelial cells. And this HIV also, as you know, it infects CD4 T cells, as you know. These CD4 T cells which are infected by HIV will make cytokines, and these cytokines will trigger the activation of endothelial cells. So this means that if someone has HIV and acquires HHV8, there is a high risk of developing Kaposi sarcoma. While someone having HHV8 may not develop Kaposi sarcoma, if they don't have these problems with immunity. So, and so on. So epidemiological variants ariyo bita classic cyangwa sporadic banayita European, hakaza endemic which is African, hakaza epidemic or HIV or AIDS associated, hakaba niyo bita iatrogenic. So iatrogenic no yatewe n'uburyo bavuwe aribyo biza ku muntu wakorewe transplantation iyo ariyo yose, kubera ko immunity ye bayimanuye hasi batazagira reaction against the transplant, so bituma immunity ijya hasi cyane, then akaba yadevelop indwara nyinshi harimo sarcoma, lymphomas and so on. So some literature they add another variant immunosuppression associated. Ariko abana bati no, this should be the same as the AIDS associated because both of them they are immunosuppression associated. So byose mbanabishyize kugira ngo nusoma literature uzamenye ko hari aho bakuraho kimwe, hari aho bongeraho ikindi, hari aho babivanga, so it depends on the authors. So this is how they look like on the skin. Abafite dark lesions ariko ntabwo zisa n'iza melanoma, ubu ubona ko ari vascularized, ubona utuveso tutambuka mutubona. Ikindi twari twinshi, melanoma kenshi bari imwe. So this is the skin region, oral regions, hari no gwifata muri stomach, so muri mucosa hari gwifata. So this is the nodula, you see that it has a form of a nodule, can it go to the liver, it can be to the lungs and so on. So hari ndiyo nakavuze hano yitwa ifata lymph node bita lymphadenopathic. So I remember when I was going to Butaro Hospital, there is a case I saw there, lymphadenopathic Kaposi sarcoma. So ifata muri lymph node ahandi hose ntayo habona. So another condition is dermatofibrosarcoma protuberans. This we saw it as a different diagnosis of leprosy. So it is a tumor which is intermediate between cancer and benign, but it is considered as low to intermediate malignancy tumor. So it affects the dermis with prominent storiform pattern. So storiform ni uraona amasere y'amagare ukuntu anyuranamo, so ameze ni cyo nshaka kuvuga storiform. So on the historicals, it is seen here on the histological pictures here. So and you see the tumor here on the trunks. So slowly grow. So it is a part of WHO classification of skin tumors, not in soft tissue tumors. That's why I didn't discuss it last time. So it is slowly growing, low-grade malignancy affecting the trunk and various sites, but it never affects the hands and the feet. So it is seen in the adults and more common in the US. It is more common in blacks. It can occur in children also, and maybe a peculiar type of nerve shift tumor since CD34. It is CD34 positive, and iyi ikunda kugaragara muri nerve shift CD34. So that's what you think people they think. So it was a chance when you do surgery and you don't remove it completely, it will recur. That is what it is challenging to treat it. Although it is not a cancer, but usually it is treated as a cancer because of that risk of recurrence. So it is a time for you to ask the questions. So no questions? Okay, so if no questions, then we can proceed with the next part. Okay, so this is the hematopathology, and this is the last part in the systemic pathology. So I think so far we have covered what entails to medicine, and if you have followed very well, it will be easy for you now to grasp the clinical sciences, because everything will be built on what we have presented here. Maybe data will be focused on signs and symptoms, investigations to do, and then how to treat. So that is what we will concentrate on. Otherwise, the pathophysiology, the science behind the pathogenesis and so on, it has been presented in this. And some of you are clever, so maybe they have also started to think about what their area of interest in the medical field. Will you be orthopedics, surgeon, or general surgeon? Will you be specialist in internal medicine, pediatrics, and so on? Dermatology, ophthalmology, and so pathology. So, and there are new fields like oncology. So I was tasked to read the preparation of the program in oncology, meaning those who will be treating cancers. So it is in my department that we have to design that. So probably it will start in the near future. So in Rwanda, otherwise those we have been trained abroad. And usually you will find that someone who has studied hematology, they are called the hemato-oncologist, because they learn most of the components of oncology, but especially oncology related to cancer, to hematologic cancers, but also they learn about other cancers. So hemato-oncologists, maybe to distinguish them from hematopathologists. So hematopathologists will focus on diagnosing diseases, while hemato-oncologists, they will just be on the side of treating hematologic cancers. So usually hemato-oncologists as our own is a medicine interne cyangwa pediatrics, while hematopathologist is a pathologist who specializes. So for example, my area of interest is the hematopathology. Maybe that's why I prepared a relatively short presentation on this. And of course, it is one of the most challenging fields in the pathology, hematopathology, like the soft tissue tumors, because there are many challenges associated with diagnosing these diseases. So we shall here have a presentation of one part, and then we proceed in the afternoon, so that we finish as early as possible. Maybe around 3 p.m. we should be done with this presentation. So this is the content we shall cover. So we have introduction, leukopenia and leukocytosis, acute leukemia, chronic leukemia, myeloproliferative disorders, lymphadenopathy, lymphomas, diseases of plasma cells, and then diseases of Langerhans cells. So this is the references, the same, but the WHO is the most current book published last year that we have used. So, but nubwo twagikoresha igitabo, ikibazo gihari muri iki gihe nabivuzeho nuko WHO classification nowadays is based on the molecular aspects of the diseases.